So I'm going over seizures. Okay, so what is a seizure? Um, it's uncontrolled electrical discharge of neurons in the brain. What counts as epilepsy? It is going to be chronic seizures. Two or more have to appear. So, two or more seizures experienced by a person is considered epilepsy. It's a chronic disorder in which repeated unprovoked seizure activity occurs, and it may be caused by an abnormality in electrical neuronal activity. So, some risk factors are cerebral edema, fever, infection, toxin exposure, brain tumor, hypoxia, alcohol and drug withdrawal, and fluid or electrolyte imbalances. What triggers seizures? What's a triggering factor? Stress, fatigue, caffeine, flashing lights. What types of seizures are there? So I'm just going to hit the highs on these, the high notes. Tonic-clonic. So a tonic-clonic may be preceded by an aura. That's how I always remember tonic-clonic. It may be preceded by an aura. It lasts typically 2 to 5 minutes. And there are 3 phases. You have your tonic phase, or your tonic episode, your clonic episode, and your postictal episode. So your tonic episode is your first episode. It's stiffening of the muscles and loss of consciousness. So that's the first step in the seizure. Your second step is your clonic episode. It lasts 1 to 2 minutes, and it's 1 to 2 minutes of rhythmic jerking of extremities. Keep in mind, I said that this part of the seizure lasts 1 to 2 minutes. Overall, the tonic-clonic seizure lasts 2 to 5 minutes. So clonic episode is 1 to 2 minutes of rhythmic jerking of extremities. The postictal phase is after the seizure. It's going to be confusion and sleepiness. This person's going to be confused. You want to reorient them, and they're going to be tired. And let's see, what do you want to do during all of these? Okay, so your nursing care. During the seizure, you want to turn this patient to the side, loosen restrictive clothing, do not insert anything into their mouth, nothing in their airway, do not restrain the patient, and you want to document the onset and duration of the seizure. So if you can, look at your phone, look at your watch, see what time it is. If you can't do a start and stop, see what time it is, and then when it's done, check the times to see how long it was between that seizure. So you want to see if it was 2 minutes, 3 minutes, 4 minutes, 5 minutes, whatever. So, another type of seizure is absence. This one is self-explanatory. Absence, you're going to have loss of consciousness for a few seconds. They're going to have a blank stare, like they could just stare up, they're not there. You're talking to them, they're gone, they're absent. They could have eye fluttering, lip smacking, picking at their clothes. With mild clonic, they're going to have brief stiffening of their extremities, so their arms and their legs are going to stiffen up. A tonic, they're going to have loss of muscle tone, and that's going to result in them falling. So think a tonic, they're going to fall. Tonic, falling. Tonic, falling. They lost their muscle tone. They fall. Status epilepticus is an emergency. You will see this a lot. Status epilepticus, emergency. It's in your books. You want to maintain patient airway first priority. You'll remember those priority questions. Second is to call the rapid response team. So, what is status epilepticus? It's a repeated seizure activity within 30 minutes, sometimes 30 to 60 minutes, depends what your book says, or a single seizure lasting more than 5 minutes. So, that's what that one is. Okay, how do you diagnose seizures? You want to get an EEG to identify the origin of the seizure. You want to see what caused it. What is your nursing care? I already told you that. So after the seizure, what do? I already told you what you do during the seizure. After the seizure, if you can, you want to check vitals, do neuro checks, reorient the patient, put up seizure precautions just in case it happens again, and you want to determine the possible trigger. What kind of meds do you give them? You want to give them anti-seizure drugs such as phenytoin. Phenytoin is also called Dilan. You have to know your generic and your name brand names. Surgeries. You have your vagal nerve stimulator, craniotomy to remove brain tissue causing the seizures. So there's 2 different surgeries. Okay, epilepsy treatment. You want to get a history on the patient, do an EEG, possible CT scan, MRI, SPECT, or PET scan, and do labs. So your drugs are your anti-epileptic drugs. You will need to check the drug levels on these drugs. You have to monitor these. You have to. That needs to be highlighted on your study guide. Anti-epileptic drugs, you want to check the drug levels on these drugs. So phenytoin, Dilantin, I always have to say them together because I remember better that way. You can give it by mouth or IV. So whenever I think phenytoin, Dilantin, I think of gums and decreased heart rate. Why? Because it can cause gingival hyperplasia and bradycardia. It also reduces the voltage, frequency, and spread of electrical discharges. The next drug is carbamazepine, which is Tegretol. You can only give it by mouth, so PO only. And when I think about this one, I think of eyes and decreased coordination. They're just like everywhere. Okay, carbamazepine, Tegretol, only by mouth, PO. And why do I think eyes and loss of coordination? Because it can cause visual problems, ataxia, and vertigo. Ataxia is loss of coordination, and vertigo is head spinning. Their head's spinning around, so they could fall. And with this drug, it reduces synaptic reactions. The next drug is valproic acid. You can give that by mouth or IV. I think GI and liver damage with this drug. Why? It can cause GI upset and hepatotoxicity. It also blocks sodium and calcium channels to prevent neuron firing. Okay, so what's the treatment? We're going to assess lab testing for therapeutic drug levels. We got to assess risk for decreased white blood cell or liver dysfunction. Remember that hepatotoxicity. Assess for gingival hyperplasia with Dilantin and phenytoin. Take anticonvulsants as prescribed. The patient can build sensitivity to the drugs as they age. Drug effects can decline and lead to seizure activity. Warfarin should not be taken with Dilantin and phenytoin. Do not give them warfarin. And absolutely no grapefruit juice because it can increase drug levels and increase the risk of toxicity. So you'll see that. Oh my God, if I haven't seen this a million times. No grapefruit juice, and warfarin is not given with Dilantin and phenytoin. If this is left untreated, it can cause status epilepticus. Status epilepticus is an emergency. That will probably be a test question some point in your life. You will read it in your books. So status epilepticus is an emergency. Maintain patient airway priority, first thing you do, and then call rapid response. There is a key difference between what do you do first and what's priority. You'll see. And I'll go over that later on. So if untreated status epilepticus, emergency, it can cause hypoxia, hypotension, hypoglycemia, cardiac dysrhythmias, and lactic acidosis. These are key things you need to know about seizures. We have some more seizures. I'll go ahead and go over those. You have your partial seizure. It's also called focal or local seizures. Begin in a part of one cerebral hemisphere. Further subdivided into two main classes, your complex partial seizures and your simple partial seizures. Most often seen in adults and generally are less responsive to medical treatment when compared with other types. You have your complex partial. May cause loss of consciousness, syncope, or blackout for 1 to 3 minutes. Characteristic automatisms may occur as in absent seizures. The patient is unaware of the environment and may wander at the start of the seizure. After the seizure, he or she may have amnesia, most common among older adults. Difficult to diagnose because symptoms appear like those of dementia, psychosis, or other neurobehavioral disorders, especially in the postictal stage. So you have your simple partial seizure. Patient remains conscious throughout the episode. He or she often reports an aura before the seizure takes place. May consist of deja vu, perception of an offensive smell, or sudden onset pain. During the seizure, the patient may have one-sided movement of an extremity, experience unusual sensations, or have autonomic symptoms. Autonomic changes include a change in heart rate, skin flushing, and epigastric discomfort. Then you have your unclassified idiopathic. It accounts for about half of all seizure activity, and they occur for no known reason and do not fit into generalized or partial classifications. New onset seizures in older adults typically are associated with conditions such as hypertension, cardiac disease, diabetes, stroke, dementia, and recent brain injury. So this is a QSEN box in your book, so it's important. Seizure precautions include O2 and suctioning equipment. Make sure the patient has an IV or saline hip lock. So again, your anti-epileptic, anti-convulsant drugs. You want to teach patients to follow up on lab test appointments, to monitor CBC and liver enzymes, and assess for therapeutic drug levels, because most AEDs cause leukopenia and liver dysfunction. Teach the patient to take their drugs on time to maintain therapeutic blood levels and maximum effectiveness. Emphasize the importance of taking their AEDs as prescribed. Instruct the patient that they can build up sensitivity to the drugs as they age. If sensitivity occurs, tell them they will need to have blood levels of this drug checked frequently to adjust the dose. In some cases, the anti-seizure effects of drugs can decline and lead to increase in seizures. Because of this potential for drug decline and sensitivity, patients need to keep their scheduled lab appointments to keep serum drug levels. That's important to know. And again, warfarin should not be given with phenytoin and dilatin. You want to document the side effects of the prescribed drugs and report it to your doctor. Avoid grapefruit juice. It can raise the blood level of the drug and cause the patient to develop toxicity. So your nursing observations and documentation of the seizure, like I said. How often did the seizure occur? You want to know the date, the time, the duration. The description of each seizure. Was it tonic, clonic, staring spells, blinking, automatism? Whether more than one type of seizure occurs, sequence of seizure progression, where the seizure began, body part first involved, observations during the seizure like loss of consciousness, change in pupil size and eye deviation, stuff like that. How long did it last? When the last seizure took place? Whether the seizures are preceded by an aura, dizziness, numbness, or visual disturbances, gustatory or auditory disturbances. And what the patient does after the seizure. Are they drowsy, weak, resume normal behavior? Are they unaware that the seizure even took place? How long it takes for the patient to return to the pre-seizure status. So again, we talk about status epilepticus. It's a medical emergency. Prolonged seizure lasting longer than 5 minutes or repeated seizures over the course of 30 minutes. Seizures lasting longer than 10 minutes can cause death. You want to establish an airway is the first priority, and contact your RRT immediately, rapid response team. Alright. So to prevent additional tonic-clonic seizures or cardiac arrest, a loading dose of IV phenytoin dilatin is given, and oral doses are administered as follow-up after the emergency is resolved. Initially, give phenytoin at no more than 50 milligrams a minute using an infusion pump. If the drug is piggybacked into an existing IV line, use only normal saline as the primary IV fluid to prevent drug precipitation. Be sure to flush the line with normal saline before and after phenytoin administration. You do not want to take any meds, including over-the-counter drugs, without asking your doctor. Wear a Medi-Alert bracelet if you can, or carry an ID card indicating epilepsy. Follow up with your neurologist, physician, or other doctors as directed. Be sure that a family member knows, or a significant other knows, how to help you in the event of a seizure. And investigate any follow state laws concerning driving and operating machinery. Avoid alcohol and excessive fatigue. Contact the Epilepsy Foundation for more info. So that is everything you will need to know pretty much about seizures and epilepsy. Like, that's everything. So I hope this helps.